Hello and welcome to this session today. We are thrilled to dive into this fascinating world of antifungal drugs with you. As future healthcare providers, we need to be able to understand how these drugs normally work and their role in combating fungal infection, which is very crucial in providing a comprehensive holistic care to our patients. Antifungal drugs do play a vital role in treating a wide range of fungal infection, which could vary from superficial skin infections to life-threatening systemic infections like the cryptococcal meningitis. So throughout this session, we'll explore the different classes of antifungal medications, mechanism of action, common indications, potential side effects, and the consideration for patient management. Remember, my aim is to equip you with the knowledge and the skills necessary to identify these fungal infections, understand the appropriate use of antifungal drugs, and provide optimal care to our patients. We encourage active participations, questions, discussions, sharing, reflection, so as to make this learning experience more enriching and more engaging for everyone. All right? So antifungal drugs are used to treat, or they are specifically used against these fungal infections, which could be fungistatic or fungicidal. Fungistatic means that they are going to be inhibiting the fungi, preventing it from growing, while fungicidal, it means they are going to be killing these fungi so it will not be there. So fungal infections can also be termed as mucosis, and which could be superficial or deep-seated mucosis. And for that reason, antifungal drugs can also be referred to as antimucotic medications. So they are normally taken over a course of 2 to 6 weeks, and they are somehow toxic, okay, to our body, and we'll be able to identify the reasons why that is so. So fungal infections majorly occur due to two reasons. One, it could be because of you have abused a broad spectrum antibiotics. So overuse of these broad spectrum antibiotics normally interferes with the normal flora, and it predisposes one to this kind of infection. Or it could be because someone has a decreased immunity, and maybe patients who have undergone transplant for some reason. It could be kidney transplant, so they are normally put on immunosuppressants, and definitely your immune system goes down. Or people could be having other chronic infections, okay, like TB reduces your immunity, HIV/AIDS will impair your immunity. Diabetic patients are likely also to suffer from this because of the same reason, decreased immunity. So generally, fungi infections are usually chronic in nature, and that's why we normally take these antifungals for a course of over 2 to 6 weeks, and they can actually be divided. They could be yeast infections or yeast-like fungal infections. They could be the dimorphic fungi or even the molds. So fungal infections are commonly classified based on their location and the depth of penetration in the body. And based on these criteria, we have four types where we could have the superficial fungal infections, which normally affects the layers of the skin, the hair, and the nails, and they are usually localized and do not penetrate deep into the body. Examples, we have the tinea vesicala, which is caused by Malassezia flavare, and the tinea corporis, the ringworms, and the tinea pedis, the athlete's foot, the tinea cruris, the one that we commonly refer to as the jock itch, and the candidiasis, the skin infections of the skin and the mucous membrane. The second group, we have the cutaneous fungal infections, which normally involve deeper layers of the skin, and this could involve the dermis and the other layers, the subcutaneous tissue. So this infection can be more invasive than the superficial ones, but typically they do not spread to internal organs. Good examples, we have the dermatophytosis, the candidiasis involving the skin and the nail. We also have the sporotrichosis and the tromoblastomycosis. The third group of these fungal infections, we have the subcutaneous fungal infections, and they do occur when the fungi invades the subcutaneous tissue, which normally lies just beneath the skin but above the muscles and the bones. So these infections are usually acquired through traumatic inoculations of fungal spores into the skin, and examples could be the mycetema, the sporotrichosis, which can also affect deeper tissues, and the rhinosporidiosis. The fourth one is the systemic fungal infections, and these are the most severe and potentially life-threatening types of fungal infections. They occur when fungi invade these internal organs and spreads throughout the body via the hematogenous route, the bloodstream. So these infections often affect immunocompromised individuals or those with underlying health conditions, okay, like diabetes, mellitus, all right? Examples we have the candidema or the critocosis or the coccicosis or the mycocosis, all right, which is so common for that case. Okay, so for the antifungal drugs to work, we must have these pharmacological target points, and these are simply based on these different structures of these fungi. Okay, so we could start with the first one, which is the cell wall. So these fungi, they normally have a rigid cell wall that is primarily composed of the chitins, right? The chitins are here, the glucagons are here, and these membrane proteins, monoproteins. All right. So this cell wall is very key to the survival status of this fungi because it provides structural support and protects the fungal cell. So if you interfere with this cell wall, man, the fungi may die. All right. So the composition of the cell wall will vary among different types of fungi species and can be a target for antifungal drugs, as we have indicated. For example, if you look at the class of the antifungals that we refer to as the echinocandins, they normally target the beta D glucagon synthase, and this is the enzyme that is involved in the cell wall synthesis. All right. So remember, for the fungi, they have a rigid cell wall that is composed of the polymer, the N-acetylglucosamine, which is a target for different antifungals. And this is possibly different from the bacteria. Remember when you're looking at the bacteria and we say that the cell wall is made of peptidoglycan, where penicillins normally target, okay? A link will be popping up on the different types of antibiotics and how they do interact with peptidoglycan to the detriment of the bacteria. But for now, we are looking at the antifungals, which are targeting this. We could have the echinocandins targeting the beta, or we could also have the other antifungals that are going to target this cell wall directly. The second structure is the cell membrane, and the cell membrane is just found beneath the cell wall. So it lies the plasma membrane, which encloses the cytoplasm and the organelles of the fungal cell. So this cell membrane, they have a key component which is normally referred to as the ergosterol, and this is analogous to the cholesterol in mammalian cells. Okay, so you see this close similarity between the ergosterol and the cholesterol in the mammalian cells. It normally poses a risk because when you give other antifungals, they might not be able to really differentiate between the two, so they target the both, and that leads to several side effects, the one that we are going to be looking at the end of this presentation. But for now, guys, we have to know that antifungal drugs such as azoles and the polyenes, they normally target this ergosterol biosynthesis. Remember, we have said that the ergosterol is a key component of the cell membrane. So the azoles and the polyenes are going to target its formation. So they could target its synthesis, or they could bind to it, and in the two cases, this normally disrupts the membrane integrity and leads to cell death. Right? Okay, guys. Hope you can be able to see the big glucagon, okay, the betas and the chitins that you have already mentioned, and now the egostrol in the cell membrane, and this is what is normally compared to cholesterol in mammalian cells. The third one is cytoplasm. So the cytoplasm of antifungal cells contain various organelles, including the nuclei, the mitochondria, endoplasmic reticulum, Golgi apparatus, and the vacuoles. Alright, guys, a link will be popping up on the cellular organization. You can be able to appreciate these different types of organelles and their functions. Alright, so these organelles are involved in cellular and essential cellular processes. It could be metabolism, protein synthesis, or energy production. So if you want to kill the fungi, you could interfere in some of these key processes, and in this case we could be taking care of this infection. The other part is the nucleus. So fungal cells, they typically contain one or more nuclei. So, and the nucleus, you know, it is the one that normally houses the genetic material, the DNA of the organism. So if you interfere with the nuclei, of course, the DNA, so there will be no replication, okay, for that case. So generally the nucleus normally regulates gene expressions and controls cell activities through the transcription and translation of the DNA into the RNA and in proteins. Alright? Okay. The other one is the mycelium. So many fungi, they grow as multicellular filaments called hyphae, and this one is collectively the one that will be forming a network known as the mycelium. And this mycelium is responsible for a number of activities. Number one, we have nutrient uptake and distribution, as well as spread and colonization of fungal organisms for that case. So the spores, the fungi, we have to reproduce through the production and dispersal of spores. So if you don't want them to multiply into several numbers, we could target this one because they are the one who have specialized reproductive structures in this kind of organisms. Okay, so spores can be produced by various means. They include sexual and asexual reproduction, and they do play a critical role in the life cycle and the dispersal of fungal infections. So all these are the different pharmacological target points for all the antifungals. But generally, we have some of the major side effects that are caused by these pharmaceutical agents, and one of the outstanding drug in this group is the amphotericin B, of which most of the side effects will be talking in reference to it. But like the first one is the nephrotoxicity, the kidney toxicity. You find amphotericin can cause the kidney damage, which leads to decreased kidney function. So patients will present with reduced urine output and increased creatinine levels. Also, beside, we could also have electrolyte imbalances. So to mitigate this, you have to ensure that you are hydrating your patient well. So we could have pre-dehydration with saline solutions and monitoring kidney functions. Okay. Additionally, we could use liposomal formulation of amphotericin B just to reduce this nephrotoxicity, and this we are comparing this to the conventional one. So the lipoposal formulation will at least be able to reduce the chances of developing kidney toxicity. The other side effect is about infusion-related reaction. So amphotericin B can cause also fevers, chills, rigors, nausea, vomiting, and headache during and or shortly after infusion. So we can try to remedy this by administering pre-medication such as antipyretics or antihistamines and anticorticosteroids just to alleviate these symptoms. Equally, we could just lower the infusion rate or interrupt the infusion and resume at a slower rate later. Okay. Next, we have the electrolyte imbalance. Amphotericin B has been implicated in causing electrolyte imbalance, particularly hypokalemia, hypomagnesia, and hypocalcemia. So patients could be presenting with the Trove signs, right? Sign and the Chebstov signs, okay, for the hypocalcemia. So the nurse needs to monitor the electrolyte levels regularly and provide appropriate supplementation to help prevent or correct these electrolyte imbalances. The other side effects is hematologic toxicity. Amphotericin B can also cause anemia, leukopenia, and thrombocytopenia. So monitoring these blood counts regularly and managing any abnormalities is required. So we could also discontinue or reduce the dose of amphotericin B if necessary. Amphotericin B can also cause liver damage resulting in elevated liver enzymes. Okay, we could also have decreased production of the ADEC vitamins, vitamin A, D, E, and K. We could also have reduced production of proteins like the albumins and globulins. Okay, so and we could also have, so this could also contribute to impaired liver function. So the nurse, you need to monitor liver function tests regularly and discontinue the drug if significant hepatotoxicity occurs as you care for that patient. You could also use the supportive care and liver protective medication. Okay, they may be considered. Lastly, you have the local irritation where amphotericin B could cause inflammation of the vein and pain. So you need to rotate the infusion site using the central venous access so as to reduce this kind of local irritation. You could also administer the drugs with lidocaine and dilute it with dextro solutions just to alleviate the pain, right? So the first group of antifungal drugs are what? The Polyenes, right? Why they refer to as Polyene? Yeah. Okay, so these are known for their activity against broad spectrum fungal infections, and they do work their mechanism of action by binding to ergosterol. Remember, ergosterol, we said, was a key component of the fungal cell membrane. All right, so when they do that, they will disrupt the membrane and cause cell death. Right, so the primary representative of this class is amphotericin B. We had already mentioned because it is the most commonly used polyphenol antifungal. All right. Number two, we have the nystatin, which is commonly used topically, while amphotericin B is used systemically for severe fungal infection. We also have natamycin, which is normally used in ophthalmic preparation, and pimagrine, which is used in veterinary medicine. Hyoscine can be used, has been used in research settings. So the other examples include the amphotericin B that we had mentioned, nystatin, natamycin, pyramicin, and hyoscine. So you find that despite their effectiveness, polyphenol antifungals are generally considered second-line treatment, and this is purely because of the potential for toxicity and the availability of safer alternatives such as the Azole antifungals and the Echinocandins for some of these infections. However, in many cases or in severe cases, you find where we have resistant fungal infection, polyphenol antifungals remain important. All right. Okay, so amphotericin B, we've already said this is the most commonly known polyphenol antifungal and is a broad spectrum antifungal agent because it's used to treat severe and systemic infections. So it's often reserved for serious infection due to its potential for toxicity. It can also be used to treat fungal infections including this invasive candidiasis, the aspergillosis, the cryptococcus, and the mucormycosis. So they are primarily effective against infections that have not responded to other antifungal agents. So amphotericin is available in different formulations, including conventional formulations and lipid formulation. Remember, our lipid formulation is the one that is preferred to prevent some of the side effects, especially on the effect on the kidney. Okay, so lipid formulation have been administered, and that's what you have already agreed. So we have common adverse effects and for the amphotericin B, and we normally use the mnemonic beam out. Right? Remember amphotericin B, vancomycin, aminoglycosides, all are involved in causing nephrotoxicity. So as a nurse, you need to monitor renal function regularly. You consider hydrating the patient and also using what we have referred as lipid formulation just to mitigate this toxicity. Okay, patient with nephrotoxicity could present with creatinine level of over 1.3. All right, we could also have a reduced urine output. Okay, that one we had already alluded to. So reduced urine output means like averagely for an adult, you expect at least the patient to be having an output of around 30 mils per hour. Okay, so if it is 30 minutes or less, all right, 30 minutes or less, that will show that actually there's a problem with the kidney. That's a bad kidney, guys. So when you look at the beam out, so the B stands for bone marrow suppression. So as a nurse, you have to monitor the complete blood count regularly, consider dose reduction or discontinuation if severe. For B is electrolyte imbalance. For tyrosine B will cause disturbance in almost all the electrolytes, more so the potassium, the sodium, magnesium. So you have to monitor this electrolyte closely and supplement as necessary. A is for anaphylaxis, so you need to have epinephrine and other emergency drugs readily available. You can also discontinue infusion immediately if allergic reaction occurs. O is for oliguria, so you have to ensure you have adequate hydration. You monitor urine output, make sure it's above 30, that is 40 mils per hour. Okay, lastly we have the thrombophlebitis. So as a nurse, you have to rotate the infusion sites. Consider using a central line if peripheral administration causes issues. Number second drug example in the pollens is the nystatin. Okay, guys, nystatin I know we have counted on several times. So this one normally treats oral candidiasis. It's a liquid suspension, so you need to shake well before use, and you have to inspect mucous membranes for irritation. So when a patient has dentures, you have to remove and soak them in nystatin because they are normally reserved for microbes, guys. And you always teach the patient to swish in the mouth for several minutes, then swallow. Okay, then swallow. Okay. So you have, when a patient is using nystatin, you have to sit it to complete the duration, even if the side effects, not the side effects, but the signs and symptoms subside. Okay, at least you have to do it, use it until 48 hours post. All right, post subsidation of these signs and symptoms. Okay. It's more toxic than amphotericin B, so thus we know we don't have systemic use. We just use it for topical and these other superficial use. All right. Okay. So the second group of the drugs from pollens, we have the azoles. Azoles, alright? Mechanism of action of azole is that they inhibit the synthesis of ergosterol. Ergosterol, we have already said, is an essential component of the fungal cell membrane. So when you interfere or inhibit its synthesis, it's going to lead to membrane disruption and impaired fungal growth. So azoles would include fluconazole, itraconazole, voriconazole. They do inhibit the fungal cytochrome P450 dependent enzymes. That's the lastrol 14 alpha demethylase. So this is normally the enzyme that is involved in the formation of this ergosterol synthesis. So this leads to disruption of the fungal membrane integrity. So there are two classes of azoles. We could have imidazoles and triazoles. Okay, the most common side effect for these topical azoles is local skin and membrane disruption. So the imidazole has no adjacent nitrogen atoms in their chemical structure, and they have two nitrogen atoms. While the triazoles, they has adjacent nitrogen atoms in its chemical structure, and it has 3 nitrogen atoms. So generally, indinazole have non-adjacent nitrogen atoms in their chemical structure, while triazole has adjacent nitrogen atoms in their chemical structure. We could have different examples for these azoles, like the imidazoles. We could have the bifonazole, butanazole, clotrimazole, iconazole, fenticazole, isocazole, ketoconazole, luliconazole, miconazole, ocomonazole, oziconazole, cetanazole, salconazole, diazoconazole. These all are zoles, the etimazoles. Alright? What about the triazoles? We have the albaconazole, the efinaconazole, the epoxy, the fluco, the isuza, the isoza, iprofi. Okay? The ravuconazole, the tehoconazole, the voriconazole. Alright? Okay guys, so remember the key thing is that azoles, they work by inhibiting the conversion of this lystrol to egostrol by inhibiting that enzyme involved in the formation of the egostrol. Alright, so apart from the indimazoles and the triazoles, we also have the thiazoles, of which ambifungin is an example for that. Okay, guys, we have already looked at the pollens. From the pollens, we went to the azoles. The third group of antifungal is echinocandins. Okay, so what's the mechanism of action of echinocandins? This one, they do inhibit the synthesis of beta. Alright, the beta D glucagon. And this one, you can imagine where they are working. They are targeting the fungal cell wall. Alright, the fungal cell wall. So this results into cell wall destabilization and eventual death. Alright? Okay guys. So examples, we have the caspofungin, the micafungin, the anilodilafungin, and they are very effective against azole resistance. Okay, so they have less side effects. Echinocandin, so they're well tolerated, so they have mild effects caused by the histamines. All right, okay. From there, we could have the fourth group, which is the allylamines. Mechanism of action, they do inhibit the sequelin exportase. So where is this sequelin exportase important? This is an enzyme also involved in the egostrel synthesis, and it disrupts fungal cell membrane and inhibit fungal growth. Okay, the allylamine that are used as antifungal are commonly like the naphthalene and the terbinafine. Terbinafine is effective against the dermatophytes, right, and the molds. The allanines do inhibit sequeline exportase and very important in the synthesis of egostrel. So we could have like here when you have acetyl A and to make this sequeline. So from the sequeline we go to the lanostrol. From the lanostrol we go to the egostrol. Alright, so for the case of antifungals, the conversion of acetyl-CoA into the sequeline, then the sequeline to lagostrol. This is where the alanine drugs work, so they inhibit this process. So no lanostrol. And even if lanostrol is created, the lanostrol has to be converted back to egostrol, which is a key component of the cell membrane. So where do azoles work? That's where azoles are going to block. The azoles are going to block this process. All right? Okay. Thank you so much. So the next group is the nucleoside analogs, and we have the pyrimidine analogs. Okay. Examples is the fluticin. Okay, flucytosine. Okay, mechanism of action, they have converted to 5-fluoroxyl within the fungal, and this disrupts RNA and protein synthesis. Okay, so guys, we have here there's the flucytosine. So we have the 5 antifungal 5-fluorouracil. So here we have the cytosine deaminase. All right. So this has to be converted to 5-fluorouracils, then the fungal RNA. So here we are going to inhibit the protein synthesis. All right. So consequently, we normally have subsequent inhibition of the fungal RNA, DNA, and RNA. Okay. Okay, guys. So next we have the grisons, and here we have Griseofulvin. So Griseofulvin interferes with the microtubule function, disrupting mitosis and inhibiting fungal cell division. All right, Griseofulvin. So it binds and interferes with the microtubule function. Okay, and this disrupts mitosis. Mitosis, that's the division, and inhibits the fungal cell division. So division is not achieved. We have some of the side effects of grisons, that is Griseofulvin, and with the mnemonic, the GRSUFR. So the G stands for gastrointestinal upset, like nausea, vomiting, diarrhea. We could have rash, where the nurse is supposed to monitor for signs of allergic reactions or skin eruptions. Or the sun sensitivity. You have to advise the patient to avoid prolonged sun exposure and use a sunscreen when they are out. Okay. Next, you have opportunistic infection, and this is due to potential suppression of the normal flora. Fatigue, you have to monitor for the signs of fatigue or weakness, and urticaria, you do watch for the development of the hives and other allergic skin reaction. Lastly, liver toxicity, you have to monitor liver function tests periodically, okay, so as to keep all this in check. The next group we have the morpholine, and an example of a morpholine is the amorpholine. The mechanism of action is that they inhibit ergosterol synthesis, and their mode of action is almost similar to azole. So this leads to disruption of the fungal cell membrane. Morpholine are a class of antifungals that acts in two enzymes of the ergosterol biosynthesis, and this is the sterol C14 reductase right here, and the sterol 14 isomerase. Okay, isomerase. So this leads to ergosterol depletion. All right, so ergosterol becomes a very serious target for most antifungal drugs. Okay, so guys, those are the generally different groups of antifungal drugs. We have the polyenes, which binds to ergosterol, and examples we have already mentioned: amphotericin B and nystatin. We have the azoles, they could be the midazole and the triazoles and the thiazoles, and they do inhibit P40 dependent enzymes. We have also looked at nucleoside analogs, supplementing analogs, and so we have a good example. We have the 5-fluorocytosine, so this normally inhibits DNA and RNA synthesis. The grison, with an example of the Griseofulvin, do work by inhibiting microtubular functions, while the Allylamines, like the naphthafine, the terbinafine, they are sequeline exportase inhibitors. All right. Then you have the thiocarbanides that do have the same mechanism like the alamides. Okay. The morpholines that we have just looked at it, we've said it inhibits ergosterol biosynthesis, and then the echinocandins like the caspofungin, the anudular fungins, they inhibit the beta glucagon synthase enzymes. Okay, so they are inhibitors. All right, so antifungals could be fungicidal or fungistatic. Remember, we had already say that fungicidals, these are drugs that will kill these bacteria, whereas fungistatic, they are just medication that will inhibit the growth and reproduction of these fungi without necessarily killing them. All right, so the fungicidals, they typically target essential fungal cell structures or processes, leading to irreversible damage and death of this fungal organism. And examples of fungicidal medications include the amphotericin B, which is a Polyene, which disrupts fungal cell wall, and the terbinafine, which inhibits fungal enzyme activity involved in cell wall synthesis. On the other hand, fungistatic drugs usually interfere with essential fungal metabolic pathways or processes, and thus prevents the fungi from multiplying and spreading. Examples of fungistatic medication include these azoles, right? Like fluconazole, itraconazole. These drugs work by inhibiting fungal cell membrane synthesis by targeting ergosterol biosynthesis. And also, we also have, apart from the azoles, we also have the Griseofulvin, okay, which disrupts cell membrane division by interfering in the microtubule formation. We have some antifungals that are classified as antibiotics, and these are those that are derived from microorganisms or synthesized based on compounds produced by microorganisms. And examples, we have the Polyenes, the Echinocandins, and the Griseofulvin. We normally abbreviate it as PEG. Alright, so amphotericin B, we have already talked about it. We say it's what you just need to know is that it is normally produced from Bacterium streptomyces nodus, and is very effective against broad spectrum fungal infections. Of course, we have already said it works by binding to ergosterol, right? Thus disrupting membrane integrity and leading to cell death. Echinocandins, these ones are derived from a natural product produced by fungus Aspergillus nidulans. And examples, of course, we had already mentioned the caspofungin, micafungin, and dulafungin, and they work by inhibiting synthesis of beta-glucan, and this is an essential component of the cell, the fungal cell wall. Right, and this leads to disruption of the cell wall and leading to eventual death. Griseofulvin, on the other hand, is not commonly used as an antibiotic. So Griseofulvin is derived from the mold Penicillin griseofulvum, and it interferes with fungal cell division by disrupting microtubule function, thereby inhibiting fungal growth. Okay, so we have the most appropriate fungal infections for each condition, like talking about the superficial fungal infections, where we are having topical antifungals like clotrimazole, miconazole, terbinafine, and ketoconazole. What about the oral thrush, the oropharyngeal candidiasis? Okay, we could have the fluconazole, the clotrimazole troches, nystatin oral suspension. Vaginal candidiasis, we could use clotrimazole, miconazole, or fluconazole orals. For a systemic fungal infection, we could have the fluconazole, the voriconazole, amphotericin B, echinocandins, especially the caspofungin. Then you have the fungal nail infections, where we use the terbinafine and itraconazole. Then you have the PCP, Pneumocystis pneumonia. Here we use the trimethoprim sulfamethoxazole. Okay. Mucormycosis, we have to use the intravenous amphotericin B or the posaconazole or the isoniazole. Lastly, we have the cryptococcal meningitis. Cryptococcal meningitis, we normally use a combination of amphotericin B plus the flucytosine followed by fluconazole. Okay guys, that wraps the end of our video on antifungal medication. Kindly remember to like our videos, and you can also go to the description section of this link so that you can be able to get a PowerPoint presentation of the same lecture, followed by quizzes regarding the antifungal and the most common type of antifungal drugs, amphotericin B, nystatin, caspofungin, flucytosine, and the treatment of cryptococcal meningitis. Okay, thank you so much.